welcome back to another episode of the Sports Medicine Project, part 2 with Dr. Peter Malliaras, tendon guru. We left you guys hanging at the end of the last episode, so get ready to fill the gaps from what we missed out on after our last chat. So I'm here with my co-host, sub 20-minute park runner, Blake Withers.
You've said that before.
Oh, well,
you're
sub
gonna say a new
90-minute
one.
half marathoner then.
I've only got one achievement to say. It isn't sub 90 because my Strava didn't get all the way. So if you look on my Strava, it still says my PB is 95 minutes.
What about sub 340 marathoner?
No, that sounds gross. You have to add in the Queenstown
Marathon Trail of Hell.
No, it wouldn't have made a difference. Maybe just marathon completer. That sounds a little bit, but it's alright. It's all relative. It's all perspective.
That's okay.
But could be Gold Coast sub 3 hour.
You reckon? I thought you said no. You're tapping out.
No.
No.
Probably the half. But I think I want to do the half because there's a couple of listeners that are doing the half as well, and I kind of want to.
Why don't you do the 63, the double, Gold Coast double, half marathon Saturday, marathon Sunday?
Let's get stuck into the week. Yeah, people don't want to hear about running. I want to hear about sports medicine, content, rehab, pain, injury.
Although tendons are pretty relevant to running, and that's what we're talking about.
Yeah, tendons are relevant to running. They are. Tendons are a masterpiece. I mean, you think of
a masterpiece
of
Why
I don't know because I'm on the third listen now of Barack Obama's book A Promised Land. The way that he can articulate words and phrases together is so, and he would have a word. I'm going to say the word incredible, but I can't keep saying that word because I've had a couple of listeners, Justin Smith in particular, tell me that he reckons I say the word incredible 50 times. And I say that because things are incredible, but it obviously loses its value.
Need to get onto the thesaurus.
Tendons are this feat of engineering. To think that, and I was thinking this when I went for a run on Saturday. I did a 25k long run Saturday morning, and I thought to myself, my Achilles tendon, my hamstring tendon, my quad tendon, the amount of force and stress it's taking to then propel me forward, and I didn't have any pain, any issues at all, and that's regular. I mean, it just amazes me that the body can do that.
I love tendons.
Yeah, even just the body in general. And for us, that's what I love to learn about, all the different structures and how they all come together to work, and then how we can manipulate that to then help our patients. But then still, we don't know enough about them to be able to say things clear cut, you know? Yep.
An endless journey.
Yeah. Well, anyway, let's get stuck into the week. You said you've been preparing all week.
I have been
However, every single time we sit down here, I've never ever seen you pull out any notes, talk
here,
to me about anything, and then if we just pause, if I don't speak, we'll just sit here in silence.
I've got things to say.
You get it started, because I've got 300 words here for my notes.
Are we talking about our highs and lows, or are we just talking about things?
Highs and lows. I want to go to the health community, and I want to do a weekly recap.
Okay, well, I'll start with my weekly recap, because it just kind of ties into everything anyways.
Yeah.
I started my Monday morning going in to watch some surgeries with a local foot and ankle orthopedic surgeon, Dr. Stephen Kent, and it was freaking awesome. I got so much out of it, and just so cool to just be able to ask endless amounts of questions for 5-6 hours, however long I was in there for, and just learn so much. And there was just so many really good takeaways that just got me really thinking about how I explain things, how I go about treating injuries, and my understanding of particular injuries around the foot and the ankle. I just loved it, and I just need to do that more often. Just things that are outside of just the clinical practice stuff that just, you just get so much out of doing things like that.
Can I ask you this? And you don't have to answer because I'm putting you on the spot, and I don't know if you've thought about it, but how does seeing that change your clinical practice or the way you think about your clinical life?
It probably, I would say seeing that helps my clinical practice in that I can better explain to patients what particular operations might look like and what they can sort of expect from the surgery a little bit more. And that's just sort of briefly touching on it, because I would leave the surgeon to explain that in more depth. But often we get a little bit more time with patients than surgeons do. So if they do have questions about it that they forgot to ask, then I think I'm able to explain it and understand that a bit better, and then therefore they hopefully will as well. My perception of what things look like.
Great. So what about the rest of the week? Tell us about Tuesday.
The rest of the week was predominantly work, and
Sweet. Yeah.
there's nothing particularly exciting that happens. It's just, getting through the day, seeing patients, same.
Yeah.
Do you want to go through every specific patient that I saw from Monday to
No, I
Friday?
completely trust. As you said, you've got it all up in your head. You don't need any notes. You've got it
What
all there.
what were you anticipating me saying?
I thought you were going to say like Monday this, then Tuesday, then Wednesday this, and I thought this Thursday, and then Friday this come up or something along
Well,
those.
you go then. Give me an example.
Tell me your week. You go.
Well, I saw all my great patients throughout the week, and they're all, well, probably not all of them doing well, but I'd say majority of them doing well.
Mm-hmm.
On Wednesday night, we went to an in-service with another surgeon, so full of CPD this week, which was on conservative versus non-operative versus operative ACL management and meniscus management as well. So got lots out of that. Good to hear the current sort of thoughts from an orthopedic perspective, because I think there's a lot of back and forth in the physio space at the moment trying to really push towards non-operative management. So it was kind of nice to be swung back in the other direction a little bit, or just at least understand why surgery in a lot of cases is completely necessary. I got a lot out of that. What about you? Did you enjoy that?
Yeah. Now you're probably thinking, why am I going to that? Being a podiatrist, and there were probably some physios there that thought the same thing, but I just find that very, very interesting. And that was through and hosted by Ripon, which is researched in Practice Newcastle. Network. So that's from Connor Glenhill and Nikki Manville. So if you're in Newcastle, look up them on LinkedIn, or they've got an Instagram as well. But it's basically just a group of physios that come together with different speakers, and it's bloody awesome. But I wanted to go because I just think that stuff is really cool. Obviously, I'm not treating ACLs.
Good networking opportunity for you as well to meet a lot of the local physios, and
that's
there was
true.
GPs there too. It wasn't just podiatry.
Yeah, that really didn't cross my mind.
It wasn't just physio.
Yeah, it was just really cool to see. I mean, I just love to learn about the body, and I just think that, especially for our podcast as well, and I just think that was really cool. The one thing that I took away from that, many things, but he was saying that although it always pinned non-operative against operative, there is no research to say that non-operative is greatly superior, or that is superior. Was that right? He was saying there is a lot of talk around the non-operative way, which of course there are cases where that may be superior, but when we research it, there is no evidence to say that it is superior to non-operative yet. A lot of people seem to be talking about that, but I guess it's obviously context specific, but I thought that was interesting to hear that from him, which is really cool. Yeah. What about Thursday, Friday? Anything interesting come of that?
In the clinical space?
Just,
Not particularly, just, seeing patients and having a good time, doing what I do best as a physio.
No, nothing, no. Cool. That's good.
You go with your bloody weekly recap.
Okay. I thought we were going to add this, we would go through, like, Monday this, Tuesday that, but it doesn't have to be.
Yeah, and what do you mean by that? I did that. I told you about the different things that happened.
I was like, how was the week? You're like, I saw patients and it was good. It was Friday, saw some and it was better. Like, I'm talking specific so people can maybe hear our experiences or how we approach something, and they'll either think, that's really cool, I never thought of it that way, or that's really stupid, that just reinforced what I already think. You're just saying, I was here, I was there, rocked in, had some coffee. But anyway, that doesn't matter. Taking notes is silly. I don't know why I did that. But I'll run through my week.
Yeah.
Okay. So Monday, it was an interesting one. In Monday morning, I saw really common for me to see a third metatarsal plantar bursa, so isolated pain under the third met head in an older lady, lovely person, walked between 6 to 10 kilometres a day, and gotten worse in the last couple of weeks. I can't exactly remember how long they've been going on for, but pretty simple to treat from our perspective. Just some deflections and footwear and, modifying their activity in the short term. But she had previously a 5th metatarsal fracture, and she was reporting that she'd had pain from shoes. So basically every time that she went for a walk towards the end would get some pain on the outside, but no pain otherwise, and just in her walking shoes or in her joggers, in trail shoes. Anyway, pretty unique foot type, pretty flexible foot as well. And I was like thinking to myself, treating the 3rd met head should be relatively simple, and we went through all the explanation of that. But I thought as well, and started explaining about a possible change in footwear, and was talking about the Topo and the Ultra brand, which is more of an anatomical fitting brand. Anyway, it just happened to be that she was a size 9, and it also happened that I had a sample from Topo of a trail shoe in a size 9.5. Anyway, puts the shoe on, and she was ecstatic. She was like, oh my God, that feels so much better. My foot feels better. Everything feels better. And I was just shocked that it was something as simple as that. And yeah, she'd bought her shoes online and hadn't really ever heard of those anatomical brands, but just incredible to see that it was so simple. And another example where anatomical shoes have a really good placement. Do you ever use them in the clinic?
I haven't used them heaps. I have recommended them for patients to try more recently since we've been talking about it a little bit more.
Yeah.
I'm keen to learn more about them though, and I still think that I have some gaps in my knowledge about the therapeutic use of footwear that I would like to fill, particularly in that sort of area, because I haven't used them heaps, and I feel like they're kind of new to me anyways. But yeah, I haven't heaps, just a few recommendations here and there.
Yeah, and it's not often. I mean, it might be 4 or 5 times a week, but it seems to be, when I have used them, and I haven't used them for very long either, but it seems to be such a noticeable difference. I mean, when people will put on a comfortable shoe, like, oh yeah, that feels pretty good, and they put something like this on, and they're like, oh, okay, now I know what you're saying when you're saying this other shoe is probably not the right fitting. So, good example. So, Topo as well are a 4mm drop, which really, compared to Ultra being 0 drop, it's not that much of a change. Like the Hoka Bondi is a 4mm drop. So
yeah, I didn't know that the Hoka Bondi was a 4mm drop.
Yeah, I don't know if they've always run. Yeah, I don't know if they've always run 4mm, but anyway.
They just look so big. Like you'd expect them to be a higher drop, just based off their look, I think.
Yeah, well, even like the Ultras. I mean, you've seen the size of them, the new Olympus Via. I mean, see the size of them, and they're 0 drop. But anyway, Tuesday. And this patient you're actually seeing as well. And I actually didn't. It was funny. I didn't realise that you had seen this patient previously. And then I saw them for some heel pain. And triathlete, lovely gentleman. And then he was seeing you for some strength stuff. And it was just funny. And that's happened a couple of times where people have actually seen us. And I always ask people, what other health professionals are you seeing? And some people are like, oh yeah, I'm going to Newcastle Performance Physio. I was like, oh cool, who are you seeing? And Kelly. And I was like, that's cool. And then sometimes I'll gauge it, and then I'll just be like, by the way, Kelly's my partner. And then, yeah, that's usually pretty funny.
I think it's funny.
Yeah. So saw this lovely gentleman. He's back doing 3 by 60-minute runs now. He's training for Port Mac 70.3. He wasn't able to run for 30 minutes without pretty severe heel pain, and things are going really well. So that was awesome to see. And such a difference. Like, I think I've only seen him maybe 5 times, and we've doubled his capacity to run. That's incredible to think you've doubled what you've done, to think how much more resilient your tissue is, or less sensitive or whatever. That was just awesome. And it's great to see their response when you say them, or you show them that when you're talking and discussing.
Do you think that their tissue became more resilient from
Yeah, I don't know.
That?
There's no way to measure it. I don't know. I would think so, because we've gone through some rehab, and we've gone through things that I would hope would increase the resiliency of the tissue. However, the tissue could have not changed at all, and they've just become less sensitive, or the pain is more manageable. I really, really don't know. But anyway, it's really awesome to say, hey, when I very first saw you, you couldn't run more than 30 minutes, and now it's doubled. And you kind of just have a bit of silence, and yeah, it was cool. Wednesday, pretty average day. Saw some patients, drank some coffee, how it is. Thursday, but 5 initials, pretty big day. Just a lot of talking and a lot of explaining. And I'm a pretty wordy person, as you've probably heard on this podcast. I think that I could probably cut how much I speak with patients nearly in half and probably get the same message across. But I don't know if it's my bias, but I value explaining and them having a good understanding of their condition. Whether or not they actually take much of it in is another story. But what I wanted to ask you, when you do have multiple initials in a day, how do you keep the energy high and really give it all you've got to that last initial at 5:30 p.m. after you've had multiple initials and other patients as well? Do you have any tips or tricks? And obviously not coffee, but anything that you've done? Because I've got one, and I'll just say it because I'm already speaking. I went into the gym and did a 10-minute workout. I did some abs, some arms, and I was sweet. Just a little 10-minute circuit, and I felt really, really good in my work gear, pants and boots and whatnot, and I felt really, really good. So I'm going to continue to try that. If I've got a bit of a time gap or maybe at lunch, it felt great. Do you have anything that you do?
Probably nothing like that specifically, but I do often, I don't know, I just kind of draw inspiration from knowing that it's taken for some people, it's taken a lot for them to book in that initial appointment, and I just want...
You go mental.
Yeah, I think so. And I just want them to feel like they've been listened to, and I think I've said this on the podcast before, I really try and emphasize that first moment of meeting a person and try and make them feel comfortable and try and make them feel relaxed. So I go a little bit overboard with saying like, hello, how are you? I'm like, what? Why are you making that face?
What are we talking about?
How do you keep... And I think that makes me feel more energized even. So I put in an effort for that first impression, and I think that you get energy from doing that. Like if you're like, hey, how you going? Then that doesn't pump you up at all. You know, you got to give it some, and I think that makes you feel more energized just in the consult anyways. Yeah,
I like it. Really the mental. Like, this is it. Yeah. What you can almost think, like, if you are seeing this person, you could be the person that changes their life forever. That could be something to draw from the energy. Yeah, that's good. But it does happen, and when you see, like, I had 3 initials in a row, the other ones were spaced out. It's interesting, and I really enjoy it, but it really does take it out of you. And it's funny because you don't do anything physically, but mentally you feel... Is it drained? I mean, and I know there's some research to show that the more empathy you provide, sometimes the more psychological stress that can cause you. That was in one of the...
I think it's hard...
studies I was reading.
I mean, if they're the kind of person that wants your help and they're there because they want to get better, and that it makes it so much easier, and I have no problem with that at all. It's as we were speaking about, was it last week or the week before, the patient who's a little bit bored and disinterested and doesn't particularly care to be there. They're the ones that I really lose motivation with, I have to really hype myself up or try and picture myself in their shoes.
Yes,
and
that's
why
good.
they're...
Their perspective. That's good. I have a patient that I see on Friday, and she's so lovely. She's from the UK. She is so fun. She just makes me laugh, and she has such good banter. And she's getting better, which is cool. But like, I get excited because she's just really funny. But anyway, Friday, really fun day, really interesting day. However, and I put this on our Instagram story, a post-operative patient who'd had some TIB post-surgeries told me, and I didn't elaborate on the Instagram too much, but I wanted to elaborate here a little bit. This person had been seeing another health professional had been seeing them for ultrasound of their TIB post, and I didn't really touch on it at all. I just asked the patient if they felt like they were getting better from that, and they said not really. And I just left it really at that and continued on. It really made me upset, and I'm not one to say that people are wrong or right for treating how they do, but I think ultrasound does cross the line. Like, it's not...
Were they doing anything else on the side?
No. I just didn't, and it's always hard. approaching that with, and I know I definitely would have said when I was a new graduate, I wouldn't have badmouthed the other clinician, but I probably would have been like, you shouldn't be doing that. There's no evidence for it. It's not going to make any difference. But I didn't even, and I thought about that on Friday, not thought about saying it, but just thought about kind of how I would hope I've grown as a clinician. But
they're not seeing them anymore?
They are still seeing them.
Oh, they are still seeing them.
Yeah.
I was going to say, if they're not seeing them anymore, then it doesn't matter.
No, still seeing them. And there'd been a lot of sessions. And this person, I think
you need to go full Dave Renfrew with that one. Ask them, just keep asking them questions. Like, what's it doing?
Yes, yeah.
What's it doing? Does it feel like it's helping? Is it... And getting them to contemplate the fact that it might not be as useful as they think it is.
Yes,
and just allowing them to come to that conclusion themselves. Yeah,
which I started ever so slightly by planting the seed on Friday and just asking, do you feel like it's making much of a difference? And I'll continue somewhere down that journey. But we were obviously focusing on other things to get started with. And I can still do all the great things, like, footwear and taping and offloading and getting started into some rehab. But it just, I don't know, it just made me really upset. And I really felt for that patient because it's not their fault for not knowing. They come to see someone expecting them to have a great understanding of what they need or what is going to help them get better. And through no fault of their own, perhaps just whatever place they picked, they inevitably end up with that treatment. And that's one of the things where I'm like, no, that's pretty black or white. I'm pretty set in the sand with that. What do you think? Like dry needling and massage and stuff, I can probably understand because it's different, but what do you think with ultrasound? I mean, it's pretty clear that...
Especially when it's not in conjunction with anything else. I think there's clear evidence to say that that's not useful in any way.
Yeah, and that's been going on for a while. Yeah.
Yeah, it's as beneficial as placebo, or placebo is probably even more beneficial than ultrasound. But I think it's just asking them questions like, what's it doing? Has it, like, how is that, what is that changing? Like, just keep asking them until they're like, nah, I don't really know what this is actually doing. Yeah.
Now, to our segment, we are talking about this week in news, this week in research. Now, we're going to briefly touch on 3 quick studies. You don't even have to say anything. You just give me the no, Blake, I'm sick of talking to you, go away, and I'll move to the next one. Or the tick, you want to maybe get into a little bit of dialogue and tell me your thoughts about that. But shared first one on the Instagram was isometric exercises for pain. And we talked about this last week when we were talking about Achilles tendon. But bent knee and straight knee, 5 sets of 45 seconds with 2-minute rest in between. There was a study done by Emmy Rio that showed a 50% reduction in pain when performing 1 of 4 functional tasks, which I thought was pretty cool. So even if you took that back to 10 or 20%, it's pretty awesome to have an immediate effect like that. They also, and I've seen this one on Instagram before, where they did a randomized control trial of looking at does foam rolling or stretching change the stiffness of the ITB, and they did one, and I was having a read of it just because I thought it was interesting, where they had 11 males, 19 females, and basically got them to stretch or to foam roll, and then looked at the stiffness at the ITB, purely just the stiffness. I wish they had some pain and then looked at that as well, but no impact on ITB stiffness at all, like it didn't change. However, I'd be interesting, and I think there is some research to show that like foam rolling and even dry needling and things can not change the stiffness but help with pain, which is fine as long as people aren't saying the stiffness is causing the pain. It's fine to do those things, would you say?
For pain?
Yeah.
Management? Of what?
Of ITB syndrome.
Yeah.
Yeah.
Yeah. I think you can do that.
Sweet.
I wouldn't be poking that area, like right onto that area though, because if it's already irritated by compression or friction or whatever we think it is, not friction, we don't think that that's the case, do we? It's more compression.
Yeah.
Is the current debate. But if it's already irritated by compression, then why is poking into that area going to help?
Going to be good, yeah. It just made me think of, I don't really have much of an issue with that being provided as information for people to try, as long as the narrative is a little bit better. So if someone says, hey, you can use this foam rolling to help with a little bit with your ITB pain, and you can use it in the short term, but this is what we're going to focus on with some hip and knee strengthening and load modification, that sounds pretty in line with the evidence. But you can say the exact same thing, but just change one line and say, I'm going to get you to do some foam rolling for your ITB because it's stiff and tight and that's what's causing your pain. Just that small shift. And I think that it's important to get those things right, because even once it's better, you don't want people thinking that I had that because my ITB is stiff and tight and I need to continue whatever is going to make it loose or make it better. Yeah.
And I think you want it to be stiff and tight.
Hell yeah, you do. You want that thing stiff as a board. That propels you forward.
So then you can just shift the narrative and say, look, the stiffer the better. Like if we want to be running fast and you want to be running long, then the
if you want to go long and hard, you want stiff ITBs.
Yeah.
If you want stiff ITBs for everything, if you want to go to the toilet, you need stiff ITBs. Walk upstairs, you want that thing stiff.
I wonder if you can function without an ITB.
There's no way on earth. Maybe you could with an orthotic underneath your foot, but not without an orthotic.
I don't know.
Yeah, interesting. And then last study was, and Kevin Kirby shared this one, they looked at 15 males, just males, no females. And you know that we always talk about that. Anyway, they had 15 males. They divided them into two groups. One group ran in a pair of the Vaporfly 4% intact. The other group ran in a pair of Vaporfly 4%. However, they put 3 cuts on the inside and the outside of the carbon plate, so it basically lost its longitudinal stiffness, and then looked at their kinematics and force and running economy, or their metabolic efficiency, and they found no difference in the metabolic efficiency. The only thing they found a difference was in a little bit of their kinetics, but mostly their kinematics, where people with the broken up carbon plate had more first MPJ excursion. So their MPJ just bent back more was the major finding, but no difference in metabolic economy.
Didn't we know that sort of, like, didn't we think that the foam was the big performance enhancer of the Nike Vaporfly, not necessarily the carbon plate? I think this was Simon Bartold saying this. I think the carbon plate was to keep it a bit more durable.
Yeah, I have heard him say that. I thought that Simon said it was the interaction of all three. So it was the foam, the high stack, and the carbon plate, all three together. So I imagine if you change the carbon plate, the other would change, or you would get some change in efficiency. But I have heard that as well, that it's in there to try and prolong the life of it. But that was interesting. I always think in my head that the carbon plate, that stiffness that we get in the plate, helps propel us forward and gives us that extra energy, which would then correlate to more metabolic efficiency, but it doesn't seem to be the case. And obviously this study doesn't rule that out, and they ran at a 3-hour marathon pace for 5 minutes, then a break, then 5 minutes again, 4 or 5 times, something like that. So again, the test conditions weren't optimal, but still it was interesting, I thought.
Yeah, that is interesting.
Yeah, well, let's end it there before you fall asleep.
Thank you.
Lovely.
I'm also hungry, so
yeah,
hungry and tired does not make for a fantastic mood on my front.
Yeah, but otherwise you're always in a good mood and a delight to be around. No. I would always say.
How about this? How about we record a podcast?
You're back, yeah.
How about we record a podcast at 6 a.m. my time time to thrive. It's always at 8 bloody p.m.
You weren't up at 6 a.m. today. You were up at like 8 a.m., 8:30.
I was up at 6 a.m.
You were not.
Me and Lane were having a chat at 6 a.m. and you were snoozing.
Should I tell the listeners what happened on Wednesday night? Or should we just leave the podcast there?
Should I tell the listeners what happened every morning?
The whistlers. You whistlers want to hear what happened. You can tell them in the morning. The listeners know. They know me. My most productive hours are 8 p.m. to 10 p.m. That's when everyone gets the replies.
So why do we always record podcasts in your hours? We
don't always record them at this time. This is very unique.
When have we ever recorded a podcast in the morning, huh?
We haven't, but
there's a side of me no one's seen yet.
I'm going to try and hypothesize why that is. Who gets the equipment ready? Who does the editing? Who does all the prep? Who does the notes for it? If you're happy to do that in the morning, I'm ready to go.
If you give me the okay to buy a Mac, then I could do these things. But I don't think my computer can handle it.
Yeah, true. That is true. I forgot that the barrier to all this is you've got a computer, but it's not a Mac, because your Windows computer doesn't have anything. You can use my Mac if you want to.
No, I can't, because you're always on the bitch.
You can't say that word on here. We're for kids.
No.
This is for a kids podcast. Anyway, let's leave it there.
Alright, wrap it up.
Yeah. Have a lovely week, listeners, and we'll speak to you all next week.
Currently leading a trial funded by NHMRC investigating an injection for Achilles tendinopathy, and that's the high volume injection. But I think injections generally, if you look at the overall, there's probably three main ones. There's steroid injection, there's PRP, and there's also the high volume injection, which is high volume of fluid with some steroid and local anesthetic. And none of them have got, I think it's fair to say, a strong evidence base supporting them. So I think that's why people have, I guess, gone away from injections or not really been keen to go there unless it's a real last resort. Having said that, they are really commonly used, and if you've got someone who's failed lots of interventions, they're very, very commonly recommended at that point. My personal view on things like steroid or PRP or even high volume is that for the right person at the right time, they're probably all possible as something you'd recommend. So my practice would be to try and inform the patient about the risks and the benefits for each one. So we know that with steroid, there is strong evidence for short-term benefit, but there are question marks over longer-term harm. So in the longer term, you might actually get a recurrence of your pain. With PRP, we know there's strong evidence that it doesn't work compared to placebo. But even when you tell that to some patients and they've tried everything, because anecdotally some people get a response, they might have had a friend or someone they know has got a response, they might be still keen to try it. And then you've got the high volume injection, which is still developing in terms of its evidence. So there's not really any good trial evidence. As I said, we're doing a trial at the moment. We've recruited 192 people with Achilles, and we'll publish the findings of that over the next 12 months. We don't know the findings yet. We haven't looked at the data. We're still waiting for 12-month follow-ups to come in, but that will help us in terms of how we sort of think about injections. But still, we don't have a strong evidence base for injections. So I don't think they should be considered as, never do an injection. But I also think they are overused massively in terms of clinical practice all over the world. And I think it's because patients perceive them as something that might help them and be easy to do, rather than what we generally recommend, which is really hard to do, and that is exercise over several months.
Yeah. Have you found, so where I work with a bunch of sports doctors and sports physicians, and injectables are a common practice. And like you said, at the right time, it can really change people's lives. And I've seen people where it's completely taken away their pain. Now, obviously, that's not everybody that has an injection, but seeing it does work in those cases. I looked for a long time to try and find any research that having cortisone to the Achilles increases your risk of rupture. And I couldn't find anything. I only heard anecdotal stuff from the doctors and other people. Have you heard anything about that?
In terms of rupture for steroid?
Yeah, like having a rupture after having an injection, like it increases your risk significantly.
Yeah. So I have seen a few people who had steroid and then ruptured after, and pretty quickly after. And it does happen with steroid. I think the key factor is where you put the steroid. So if you put the steroid into an Achilles tendon, you massively increase the risk of rupture. If you put it around the tendon, my anecdotal experience is that risk of rupture is much lower. I've seen people who are young, in their 20s, have a steroid injected into the Achilles tendon and then they rupture. These are not people who are old and got degenerative tendons. They've got relatively okay. It's still pathological, but not like you get when you're 60. But they still rupture. So I think into the tendon, it should not be done at all. But around the tendon is probably a different story, and we just don't know enough about the long-term effects. But my impression is you can still get ruptures, but it's much, much, much smaller risk than into the tendon.
Yeah, and talking about kind of those more passive modalities, and assuming the goal is for someone to get back to their activity or their meaningful activity pain-free, where do you find passive modalities sit in relation to tendon rehab? As an example, like dry needling and acupuncture and shockwave and massage. And I also imagine there's lots of ways to answer it, but does it change in regards to the specific tendon or the modality, or what's your thoughts on those?
Yeah, look, I think they probably have a place, but a very small place. If you go to the evidence and answer it based on that, again, the evidence is really not very strong for any of those interventions. Arguably, shockwave therapy has a better evidence base and a developing evidence base compared to some of the other ones, but still not really a strong evidence base. If you look at it from a, say, clinical, practical point of view, adding those interventions could be helpful for pain in the short term, could be argued, even if that is partly a placebo effect, that's fine. But the trouble with that is how much are you cutting into your time to do other interventions that we know are effective or possibly more effective? So, counselling the patient, education, transferring self-management to the patient, and then setting them up with a sort of activity and exercise advice that they need. So my preference would be to try and fit all those things in. And I don't find that I generally have time to do a lot of other things once I've done that. But yeah, as I say, a small part of treatment, it could be acceptable.
Yeah.
Yeah. I guess it comes down to the goals and what the patient wants. If they're wanting to get out of pain for a short period of time, then that's when maybe you might be able to help them out with some of those passive modalities. But I'm not convinced that dry needling it is going to help them to get back to things like running without a lot of emphasis on the importance towards, loading and exercise.
Yeah, I absolutely agree with that. I think it's good to take a patient-centered approach, and if the patient is really keen to get, an improvement of pain in the short term, then it could be something to try. And I do use shockwave therapy, and that is something
awesome.
that, yeah, you can get a short-term benefit for some people with shockwave therapy. So it's definitely, I think looking at the patient's goals is important.
Yeah, we use that and see, and it's hard and I always posture it to the patient. Same because we see lots of heel pain as well. We always posture it that it's probably not the shockwave in isolation that's getting you better. It's a combination, but it's always hard to know, is it the shockwave or the fact that you just now have been doing your rehab for 4 weeks and that's why it's improving, and you slept well and did everything else right. It's always hard to know.
Yeah, I agree. It's difficult in the clinical context.
What do you think, like for the very general common presentation, somebody comes into the clinic with a sore tendon between that kind of 3 to 6 month mark, wanting to get back to activity, and speaking more specifically to the rehab and understanding, I guess you meet the patient where they're at in regards to kind of the rehab continuum, but what do we think the tendon generally needs? I know we touched on it a little bit before, but I know for, Achilles tendon, we think, isometrics and then isotonics and then slower rates of loading and then faster rates of loading and then energy storage and release. Is there a kind of, I guess, a tendon spectrum or continuum that you generally follow?
I think probably if you look at what you've described there is probably a comprehensive approach and pretty much the way to go. And you want to look at the person as an individual understand what type of impairments they have. So I look at exercise as a way of, I guess, first and foremost, empowering the patient to be confident with loading. So that might be enough for some people. And then you might just be doing some really, it doesn't have to be too specific, it can be quite general loading just to improve confidence. And it might be based around some of the things they find difficult or find threatening and not necessarily following exercise adaptation principles. Then you have other people who have got more impairments. So they've got strength impairments and hopping impairments and other problems. So for those people, you might do more specific interventions with specific outcomes, looking at trying to address some of those specific impairments. So then you might go down more of a heavy, slow resistance approach, which is a little bit more geared towards adaptation of the muscle tendon unit. So then following that with other interventions like hopping, and before you start then looking at return to running and sport. So I guess it sort of does depend on the person. It's also dependent on where they've got pain and painful activities. So yeah, I think probably looking at exercise more broadly as a way of just building confidence, addressing pain, but also then looking at adaptation. So not everyone needs to go through a very comprehensive, loading program where they do everything. It can be quite tailored and individualized depending on the person.
Yeah.
That's cool. Could we talk about the difference between reactive tendons and degenerative or persistent presentations, and sort of including like the pathophysiology and the differences that you might see in rehab?
Yeah, for sure. Yeah, look, it's so the Jill Cook and Craig Peter model from 2009. That's really a popular way of categorizing tendons. So people look at reactive as, very, very painful. They sort of, very irritable. They flare up for days after you do certain things with them, whereas degenerative is more, not as irritable. There's still pain, but sort of background level. They sort of also then relate that to the pathophysiology and the pathology within the tendon. So reactive might not be as progressed, degenerative is a little bit more progressed. And then there's also reactive on degenerative presentations where you've got acute sort of flare up of pain, but the tendon isn't, so the tendon's still degenerative with that pain presentation. The problem, I guess, with that model is that it's very hard clinically to assess pathology unless you've got ultrasound. And even when you do have ultrasound, it's not really clear and you can't really detect those types of presentations. So it's really clinically you're driven by pain, and you're looking at reactive as very irritable and the degenerative as not as irritable. So really pain is the guide clinically. And I go based on things like how much aggravation do they have after certain activities like stretch, shorten, cycle activities like walking and running. How much pain do they have with those activities when they're doing them? So those types of things can guide how irritable they are and then what you do with them. So that's sort of how to apply it clinically. So it is a really good model, but I think you can sort of simplify it down and just call it irritable pain versus not irritable pain, which is sort of how I sort of deal with it clinically, where you haven't got the luxury of knowing what the pathophysiology actually is.
And do you think it changes rehab if you're dealing with a reactive versus a degenerative tendon?
Yeah, it's a good follow-up question. I thought you might ask that one.
You're on fire today, Kelly. Far out.
I don't think it does too much. So I think we just don't know. Clinically, you're dealing with pain and you sort of want to get them tolerant to pain to be able to load and do the things they want to do. I don't think we know that, if you've got a degenerate tendon, you've got to do this, this, and this with it, as opposed to another tendon. I think what we should be thinking about is more broadly. We should be thinking we've got a tendon that's painful. we've got a tendon that's probably not at the level of health that it should be at, and the person is expressing pain because of that, and that could be for all the biopsychosocial reasons we talked about. So we should do something to make the tendon more healthy, like the high intensity loads we talked about, but we also should consider the whole person, how and really sort of loading and other factors that we can also modify to maybe help their pain. So I think thinking about it as degenerate and reactive and doing specific things, I don't think we have any basis for that. But thinking about it as you want to make the tendon more healthy, because we've got evidence that it's not coping, and the evidence for that is just the pain that it has, I think that's a good way to go.
Evidence that it's not healthy. I like that.
Keep it simple.
And then I have one more question.
Yep.
For you as well, which you mentioned imaging before, and I just had a flashback to your course that I did maybe a couple of years ago, where you were talking about ultrasound for glute tendons and the difference between like being able to differentiate between a glute tendinopathy and a glute tear, and they looked at a bunch of different radiographers, and there was just so much variability amongst what they thought the diagnosis was. Is that still the general consensus, and is that just for glute tendons, would you say, or all of any tendon throughout the lower limb in particular?
Pretty much for every tendon, yeah. So there's we actually did a consensus process. When was it? Back in 2018, we got together a group of international tendinopathy experts and researchers, and we sort of met up and tried to develop consensus about various things like the outcome measures we should use, and even things like terminology, what we should be calling tendinopathy. And one of the sort of, I guess, items that we wanted to discuss at that meeting was imaging, and whether we can reach consensus about, how to image, what we should be imaging, how to sort of grade imaging. And that sort of fell apart because we realized that it was just too difficult and we didn't have the right expertise in that particular meeting. But I think it is it's a real challenge. I think looking at imaging, I had a patient yesterday who came in and he had an Achilles mid-portion problem. He was 67 years old. He's got typical really thick tendon, and he was diagnosed with a 3 centimeter tear within the tendon. And when I looked at it under imaging, it was clearly a tendon that was having a sort of heterogeneous echogenic pattern. And what I mean by that is it was just black little lines throughout the whole tendon, basically, that shouldn't be there. So calling those a tear is, I think, a bit of a stretch, because we don't really have the evidence to know that that's a tear process and the patient thinks they've suddenly torn their tendon. So that's an example of just how people just are calling things pretty much whatever they want in the tendon, and we've got no consensus about what a tear is or how to grade tendon pathology at all, aside from the size of it, because that's easy to measure. So it is a problem, and we probably will get there, but it's going to be a tough road to bring everyone along for consensus of imaging, given how much diversity there is out there in understanding and opinions at the moment.
Do you ever have you had cases where you've put someone in a cam walk or a boot ever for a tendon injury, and specifically talking about an Achilles or a peroneal or a tib post, or is that only in a ruptured case?
Yeah, look, even the guy that I'm talking about last night, like he came in, and it was a really interesting case. He had a total knee replacement 2 months ago, and he developed the Achilles problem 2 months before he had the total knee replacement, and it was on the opposite side, so it was clearly related to favouring his other side. And he now, even those 2 months post a major operation, the Achilles pain is much worse than any problems he's got with his knee. And he, when he was walking, he had severe pain just walking. and he only walks a few hundred meters per day. So someone like that, you would consider getting them into a boot just from a pain point of view, just to allow the tendon to recover whilst he's doing exercise out of the boot every day, just for the walking. So we did talk about it. He was resistant to it, so we went with 2 heel wedges and really good footwear. So he's going to go down to he came in with really crappy, you'd probably like this, Blake, and you've seen this quite a lot, really floppy, sort of, non-supportive shoes. I think they were Skechers.
I thought you were going to say he was in like the Vivo Barefoots or something like that with the little toes around it.
Not quite, but sort of the next step from that, he had Skechers on. So they were basically offering no support whatsoever. No heel wedges in there. So I got into, he's going to go down and get probably some Hockers or something today with 2 heel wedges. But I've given him the heel wedges, and he's going to take them down to the shop so they can fit him at the shop with trainers that fit without his heel coming out the back of it. So, and even yesterday with his Skechers with the heel wedges, his pain went down pretty dramatically just with the heel wedges in. So you can achieve a lot with just some of those interventions, but for some people, if you can't, and what we said yesterday was, if your pain is still pretty bad next week, we'll consider a boot for a week or 2. That reasonable.
Yeah, you did pretty well. That's half my podiatry degree, learning how to put in heel wedges. You're halfway to becoming a podiatrist. I did want to ask around the follow-ups and, being a clinician for your amount of time and seeing patients for several years with these tendinopathies, and knowing that, it seems to be the biggest risk factor we have for any lower limb tendinopathy is having a previous tendinopathy of the same nature. Do you find, and I always posture to patients now when it's the last appointment and I'm about to discharge them and saying it's probably likely or it can happen where you may have a flare-up in the future. I've just seen that with people with tendinopathies, and especially Achilles tendinopathy in runners, and trying to give them all the self-management strategies. Do you see that the ones that you manage with any lower limb tendinopathy, even once they're back to 100% and you've discharged them, sometimes they do get these flare-ups over the years, and they might give you a call, and usually it's okay. It's just something that the tendon is now a little bit more sensitive than what it was?
Yeah, without a doubt. There's definitely, and there's even evidence out there, it's from football, suggesting that the rate of recurrence is really high. So a lot of, people do suffer recurrence really commonly. And I think what you're doing is spot on to say, look, basically musculoskeletal injuries are a bit of a revolving door, all of them. So, OA.
I like that one, revolving door.
OA, tendinopathy, whatever it is, it is a revolving door. So you've got, and you're also right that is an established risk factor. So if you look at Achilles tendinopathy, one of the risk factors is previous injury to that leg. It doesn't even have to be a tendinopathy, just an injury. And so I think, sort of telling them that it probably will come back at some point is probably important as part of their, education, I guess, ability to stay with the exercise program, or at least do something to mitigate their risk, like being really careful with their loading. So it's part of the process of setting them up with longer term strategies to be able to cope with that, but also not be too surprised. But you do have people, especially when it's a really bad one. So I can remember quite a few people along the way where they've had a really bad tendinopathy that set them back for years, and then they get it better eventually, and then they get the other one that comes on the other side, and they start to panic because they think they're going to go through another few years of the same stuff.
Yeah.
Often it's not as bad because they've got the education. They're not doing the same things they were doing before. So often it's not as problematic for them, but they tend to panic because they think they're going to go down the same path. And spend thousands of dollars and have to see all these different people. So it can be a little bit scary for them.
Yeah, I want one final question, and I did want to quickly touch on your courses as well. But would you say there are any factors that clinicians should be aware of and maybe make aware to their patients of what can affect the rehab time. Like I usually go through something of the lines of, it's in the lower limb, you're putting a lot of stress to it, even when you're not doing activity, just when you're walking and moving, and that can kind of play into it not getting better possibly as quick as probably what we think it should. But is there any factors that you think influence tendon healing that clinicians aren't aware of?
Yeah, I think all the sort of key risk factor groups. So things like metabolic health. So, for example, if we go back to this patient from yesterday, he weighed 117 kilos, and he was probably I'd say 5 foot, 7 or 8.
Yeah.
So he was definitely obese. He had hypertension. He had cholesterol. He'd been on statins for 30 years. So those factors are really going to make a huge difference in terms of getting someone better. So what I said to him and what we planned to do, there were 3 things we did as intervention yesterday. One was very basic loading, which is just an isometric in standing. And he could only do it double leg because he wasn't able to do single. And then we also did the heel wedges that we talked about. And the third one was get him to an exercise physiologist, or at least considering that, to do 2 or 3 sessions a week of physical activity, and sort of look at his body fat and how that's changing. So I sort of said to him, look, if you do one or the other, you're probably not going to have a good outcome. But it's also things like hormonal factors for females. It's things like really severe other injuries where they've had long-term weakness and issues that they've dealt with that would also be a factor. So I'm seeing someone at the moment who's got an Achilles problem, but it's on the background of a very, very bad knee PFJ issue that she's had for a long time, which still isn't really where it needs to be. So there's a whole stack of factors that we can probably address as part of treatment. Then there's people that are just genetically, I think, predisposed to having a tough time as well, and they often have bilateral issues. Sometimes that's explained by inflammatory problems, sometimes it's not, and you just have to then be conscious of that as well. And then there's a whole and then there's another group of people who don't get a good outcome, generally because they don't adhere to the things that we tell them to do. So the ones that don't really like exercise, and that's where you can also, going back to the conversation we had before about adjuncts, you can start to think about shockwave or other things for people who are not so good at doing exercise or don't want to do exercise as well.
Yeah. Great. And lastly, so how can people find you? I put this, and we will put this in the show notes, but your Instagram handle, but I know you've also got, as Kelly mentioned, she's done one of your courses before. You've got a whole website, tendinopathy rehabilitation, and all your courses are online. Are you doing any in-person ones as well to find your information?
Yeah, look, thanks for asking, Blake. I'm doing so this year we've got a few courses booked or ready already. We've got so it's tendinopathy.rehab.com, and they're on there, but also they're on sort of all the Twitter. I've done some posts about them, but I think we've got so far Sydney in April.
Oh, cool. Newcastle, not far north. Have a look at that.
Yep. Sydney in April, and then we've got Melbourne, and then Perth at some point over the next few months. So we've got 3 that are booked so far this year. It's basically just a bit of a deep dive into assessment and management.
Yeah, that'll be awesome. And I'm pretty sure it says, I'm looking on the website now, and it says if you can do 1.8 times your body weight, you get 20% off. Is that right?
That's good. I might incorporate that. It's not.
It's something ridiculous like 3.8. You just have all these people training for like 8 months.
Send us a video of you doing 2 times your body weight, and you get half price. That's not a bad incentive.
Yeah, that's not too bad. Disclaimer: if it ruptures, you can't sue though.
I like it.
Yeah, that's good. All right, Peter, we'll let you go, mate. Thank you so much for coming on. It was great. I mean, we've been looking forward to this for several months, and I know Kelly and I spent a lot of time with the questions, and we narrowed it down from about 30 or 40. So I really appreciate you taking the time and helping out, and we'll definitely link all your stuff in the show notes as well.
Fantastic. Thank you very much for having me.
Thank you.
Thanks a lot. Thank you for having me.
See you later.